Yeah. Is my presentation visible?
Yes.
Yeah.
Okay. So I'll be talking a bit about endogenous endophthalmitis in the COVID era. So here, sorry. Uh, yeah. So what cases I'll be showing you are mainly from the second wave that we encountered in India. And here I'm talking predominantly post the Delta variant, not after the Omicron variant. We have not seen such cases at present. And during the Delta wave, we had a very high rate of hospitalization, and a lot of patients were put on steroids or even other various immunosuppressants and received various kinds of intravenous therapy. And probably also COVID-induced immunosuppression contributed to this cases of endophthalmitis. So our oculoplasty colleagues were busy managing this orbital mucormycosis, which was also really, really dreadful. But the cases that came to us were more of endophthalmitis and endogenous, and most of them we found were rather related to Candida. So what are the risk factors? In any case of endogenous endophthalmitis, risk factors are an immunocompromised patient with long abdominal surgeries, or even intravenous infusion lines that we have already seen in India, that certain areas, just the presence of intravenous infusion line can lead to endogenous endophthalmitis. Now, over added to this was probably COVID and sometimes in inherent diabetes of the patient and steroid use and other intravenous infusions. So mostly what we saw was that these lesions started as focal lesions in the posterior segment and mostly whitish in color, mostly avascular, and spread was seen from choroid towards the vitreous cavity. But recently, we have also seen primary retinal infection, and that has also been described in literature. I'll show you a paper on that. And this slowly progresses and keeps on causing vitreous inflammation, which may also reach the anterior segment, finally a full-blown pan-uveitis endophthalmitis with hypopyon. So the first case I'm showing you is a diabetic female, a 60-year-old. Patient was 3 weeks post-COVID, had received steroids, had decreased vision in the left eye. On anterior segment examination, there was definitely signs of inflammation. The posterior segment showed this white lesion with fluffy borders, a deep sort of lesion with significantly reduced visual acuity. On performing a swept source OCT, we found that there was a large area of retinal thickening at the center and some amount of with shadowing and some amount of subretinal fluid and some irregularity at the level of the retinal pigment epithelium choriocapillaris juncture. So we made a provisional diagnosis of metastatic fungal endophthalmitis. We went ahead with a 25 gauge vitreous biopsy, and at the same time we injected intravitreal voriconazole. And the calcofluor white KOH staining of this smear showed budding yeast cells, which confirmed further our suspicion of it being fungal and Candida. So this was 5 days after the initial injection. We do not see a significant change there. We continued with intravenous management with voriconazole itself. And at that time, we wanted to change over to IV amphotericin B, but the patient developed an allergic reaction to it, so we could not. And subsequently, our infectious disease consultants advised that we start her on tablet posaconazole. Simultaneously, we also started treating her with intravitreal antifungals. And we gave her around 4 injections of a combination of amphotericin B and capsofungin at an interval of about 2 to 3 days. And finally, she was discharged on tablet posaconazole. And the culture also finally grew Candida tropicalis. So it was not Candida albicans, but Candida tropicalis. And probably these other subspecies of Candida are much more virulent, and we probably need to treat them with these combination, as we saw in our cases. So this is after a few weeks, we see that the central lesion is becoming more consolidated, but you're seeing some retinal hemorrhages developing. As we go along, the central lesion seems to get scarred, but you are having some exudation at the RP level. So this means that there is some breakdown of the outer retinal barrier also there. And OCT is a good means to assess the height of the lesion and see whether the response is there. And we can clearly see that the lesion is reducing in height. At 6 weeks, the patient does recover good visual acuity with central scarring, but yes, the surrounding ring of exudates remains like a succinate ring there, but probably this is not the breach of the outer barrier rather than the inner barrier. And there's resolution of subretinal fluid. And finally, when we discharge at 2 months, when we saw her, she had recovered about 6/60 vision. And slowly, then we also stopped her oral medication at about 2.5 months. This is another case, a 25-year-old male. So this patient is young patient and not a diabetic or any other risk factors. Again, 3 weeks post-COVID, but this patient had received steroids. And the patient had decreased vision in the left eye. And left eye had been significantly involved and operated somewhere, but there was no recovery of vision there. When the patient came to us, we saw that the right eye also had a single lesion. So here, since it is extrafoveal, so patient did not have visual complaints, but yes, the same whitish lesion was there around the inferior arcade. OCT again displays that this lesion is there in the retina with a lot of shadowing. And here the choroid relatively appears undisturbed. Although there is shadowing, but still the surrounding one does appear to be undisturbed. Visual acuity was good, but signs of inflammation present. We again went ahead with a vitreous tap with a single gauge 25 gauge vitrectomy port and injected voriconazole through the same. And working diagnosis was again Candida endophthalmitis. Started the patient again on IV voriconazole. And then we shifted to amphotericin B, but unfortunately in those days there was a lot of shortage of amphotericin B because it was being used for the orbital cases, and we could not give it for a long time and had to shift in this patient again to posaconazole. So here, in view of the good vision and it's being the only eye, we were a little hesitant of giving repeated intravitreal injections. And for 1 week, we thought, let us treat with the intravenous medication itself. But at 1 week, as you can see, maybe there's a slight shift of the lesion, but the significant lesion still persists. So we did start injecting with the same regime where we had found a good result in the previous patient. So an amphotericin B plus a capsofungin injection at about 48 to 72 hours interval, and kept monitoring the height of the lesion with OCT. You can also see the OCT shows us these vitreous cells there. So here now we see that the lesion has definitely started shrinking. And further we see it is moving. The active part is only present inferiorly, but it is definitely reducing in height. And on OCT also it is quite clear. And finally, we see that it's basically a scar. This photograph has been taken now at about 4 months. So this patient was again also given oral medication for about 2.5 months. And after that, we stopped everything. But probably the maximum response, what I feel, was mainly because of the intravitreal therapy here. Left eye, unfortunately, went into a painful blind eye and had to be enucleated later. And that also confirmed the diagnosis of Candida. So in relation to these, I just wanted to highlight 2 papers. So this one paper by Alessandro shows OCT features of Candida endophthalmitis. So here they have clearly shown that there are 2 patterns of endophthalmitis. Earlier, we used to think that it is primarily only the choroid which is the source, but they have also shown that it can be the retinal circulation which can be the source. So pattern A can be chorioretinal and pattern B can be primarily retinal alone. And the cases with primary retinal pattern probably have a better prognosis as per this paper. So I think that the second case we saw in our series was also a primary retinal case. The first case is probably a mixed chorioretinal one. These are pictures from their paper. So here they've clearly shown that you can have isolated retinal lesions. Probably they've caught the case very early. And the other one has this chorioretinal lesion with changes at the RP level and the choriocapillaries also, inflammatory changes there. Now, this is another interesting paper which shows that in COVID patients who develop severe COVID, they also develop autoantibodies against type 1 gamma interferons, type 1 interferons. And type 1 interferons have known to play a role in preventing fungal infections. So perhaps COVID could be inducing a susceptibility to fungal infections by inducing autoantibodies to these interferons, but probably this needs to be explored further. So just to summarize, what we saw post-COVID, the intraocular infections were mainly fungal and that to Candida, and it can present in 2 forms, a primary retinal or a chorioretinal form, and the treatment should not be only intravenous antifungal therapy, but a combination of intravenous therapy with intravitreal injections. And voriconazole we found not to be that effective as it also has a shorter half-life. And since these cases probably need multiple injections, just an amphotericin B or a combination of amphotericin B with capsofungin would probably be the treatment of choice. And I would say vitrectomy should only be reserved for cases where there is significant vitreous involvement and cases where you have just retinal involvement or chorioretinal involvement, we should try managing with intravenous therapy and intravitreal. Thank you. Thank you very much.